So let's start with RESONATE-2, and it gets to the same issues that we've just discussed, and that is the design of the trial. So this is for the treatment-naive group, patients who meet criteria for treatment, standard criteria, but age 65 and older, and have never had prior treatment. Importantly, patients with del(17p) were excluded, so we don't have that data in the upfront setting in a randomized setting. And then it was ibrutinib until progression versus chlorambucil. The dosing schedule is shown here. This trial did allow crossover. Or if patients had chlorambucil and they had stable disease, not better, by 6 months, they could elect to stop at 6 months instead of taking a full year of chlorambucil, with the idea that they would progress sooner and could cross over sooner. Or if they had better than a stable disease, they continued for the full year and then stopped chlorambucil. So that's the trial design. Here's the demographics. So here we are finally dealing with a somewhat typical patient population, right? Patients in their 70s when they receive their initial treatment, unlike most of the trials that we've done in CLL, including the FCR trials, by the way. And a couple other things to point out: about half the patients had stage 3 or 4 disease. You can see the SIR scores here. Most were fit, and here's the renal function. I'll remind you, though, you can have a patient in this age group who have a creatinine of 1.1, and they're going to have a clearance of less than 60. So I think my personal view of these measures is that they're really not worth much at all. This is a made-up number in my view. It's just a glorified review of systems. So I think this fit and unfit business is a little bit overblown. Here's the bottom line: progression-free survival. So it doesn't surprise anybody. You certainly wouldn't have shorted this trial in favor of chlorambucil. If it didn't turn out this way, it would have been shocking. So again, to Wyndham's point here, this is done strictly from a regulatory standpoint. I put patients on this trial because I can get them ibrutinib. And, you know, if they wanted to take chlorambucil for a while and then cross over, then they would get that. Because I certainly don't use chlorambucil as frontline treatment for anybody. And that's pretty typical in the US. It's just, you know, it's different because we have the availability of all the other drugs for better or worse. So from a US standpoint, this is one of those examples of what Wyndham was describing, that it's done in order to get a drug approved. Because chlorambucil certainly is not the typical drug used for this patient population. In fact, as I mentioned, the typical drug used for this patient population is single-agent rituximab, which is a terrible choice, of course. But that's the reality. And if we look at the higher risk groups in this study, the del(11q) or the mutated versus unmutated, here's again the mutated ibrutinib arm. So very reminiscent of the data you saw earlier in this group with FCR and the long-term follow-up with FCR. And overall survival also superior at this short follow-up, 24-month overall survival, 98% versus 85%. I'll remind you, we did have a small group, 31 patients in the original trial with ibrutinib, age 65 and over, previously untreated. 1 patient progressed at 8 months. No one else has progressed. And I have 3 patients still on that trial who've been taking ibrutinib for over 6 years. So this is very consistent with our earlier data. Responses here, typical CR rate that you see with chlorambucil in virtually any study that's been done in CLL in this population, 5% or less. And again, most of the responses you see with ibrutinib, of course, are partial responses. We don't see clearing of the of the bone marrow, certainly at early time points. So here's a summary of the exposure to study treatment so far. So many patients here didn't complete the full year of chlorambucil. 10% of patients had some dose reduction of ibrutinib, and you still have 87% of patients continuing treatment at the time study of completion. Now, this, I think, is an important point. So you saw a slide, I think, from Paulo about how patients do after they progress on ibrutinib. That was the publication from MD Anderson, and they all die, right, in a matter of months. And that's the wrong answer. That's the wrong answer. And I think it's created a lot of confusion because all those patients that they're reporting on are the patients on the early trials, the relapse refractory. Again, I have never seen such bad CLL in my life in patients who went on that trial. They've had everything else. So when they do progress, and they do, it's not surprising that they die quickly because we don't have good options. But what's more relevant to us is a patient population like this, initial treatment, or maybe somebody after first relapse who had FCR 5 years ago. How are they going to do? That's the questions that our patients ask us, certainly ones who are considering using this as front line. So I think this trial will be very important, not because it shows it's better than chlorambucil. It'll be very important as we follow it out over the years to see the natural history of the disease if ibrutinib is used up front. So 12 patients stopped because of AEs, 11 are still alive, 3 progressed pretty soon, but 2 didn't have to start any subsequent therapy, 1 started BR. 3 started subsequent therapy after stopping from an AE right away, 2 with FCR, 1 with chlorambucil, interestingly. Here shortly after discontinuation. 5 were progression-free without subsequent therapy. 1 died of pneumonia after discontinuation. Now, only 2 patients so far discontinued primarily due to progression. These are the ones, of course, we're most interested in, but we only have 2 so far. Both are alive without subsequent therapy. So again, I think it's going to be really, really important to see how these patients do over the years, especially how many are going to progress. Is that going to be fundamentally different than what we're seeing in the earlier trials? Safety issues, very consistent with the RESONATE trial and the DEL-17P trial. AFib, you see 6, 7, 8%. Major hemorrhage. Here, no statistical difference between the arms, but again, consistent with what we see in the subsequent trials. Easy bruising is very, very, very common, and in some cases, it's really significant enough that patients really don't want to stay on treatment. But in terms of major bleeding, fortunately, we don't see that as a spontaneous event. And interestingly, what we're seeing now from the early trials as a later side effect is hypertension. So I think that's real. And so it's something to keep in mind if patients stay on the drug for long periods of time. So that's our data for upfront ibrutinib so far. There is a randomized trial going on in the US for younger patients age 70 and below. It's meant to be an FDA registration trial, and that's FCR versus ibrutinib and rituximab. So that trial is almost fully accrued, and we'll have some data from that as we go forward. The second study is HELIOS, and this is for patients who have been previously treated. And again, it excluded patients with DEL-17P, and it's typical BR versus BR plus ibrutinib. Again, bottom line, primary endpoint, progression-free survival. Not hard to understand that if you add an active drug to chemoimmunotherapy, you get a longer progression-free survival. So again, this is not a shocking result at all. And there is a benefit here in terms of overall survival as well. Here's the side effect profile, very consistent with what had been seen previously, and it was very similar between the two groups. Chemotherapy, so combining it with chemotherapy didn't introduce new toxicities. Same thing with the rate of infections between the two treatment arms. They were very similar. And then again, the AFib signal in yet another study comes up right here. Bleeding side effects also consistent with what I showed you even in the upfront study. So we have, that was really kind of the second study, a randomized study in the relapse refractory setting after the RESONATE study. To me, personally, it's sort of ho-hum. I'm not interested in adding an effective, expensive drug to standard chemoimmunotherapy. I'm interested in eliminating chemoimmunotherapy. So, of course, the more interesting study would have been ibrutinib versus ibrutinib plus BR, but it's not hard to understand why this study was done this way and why we'll never see the study that I just mentioned done. But there's another example of regulatory versus what you'd like to see from a clinical perspective. So if you like to use BR and you want to add something to it, you've got the data to support that. Otherwise, I would say I see no reason not to use single agent ibrutinib. Questions?
One comment, and this is relevant to my earlier comment where I, regarding do we have evidence that coming in with ibrutinib and 17p people up front will improve OS compared to using it later. In this trial, even though you had a crossover, you still saw superior OS on the ibrutinib arm. And this plus what Mark had already mentioned, that we already see that ibrutinib works well in 17p, certainly I think provides very convincing evidence that using ibrutinib up front in 17p will probably give you a increased OS over waiting.
Yeah, probably will, but unfortunately, we won't have that directly from that trial.
One thing that we learned across all studies, idelalisib ibrutinib, and we didn't know a few years ago, is that indeed we cannot recover, even with these very good drugs, we cannot recover our patients. So we didn't expect. I also remember with the idelalisib versus rituximab, we thought, okay, there is a crossover, who cares, we start treating with rituximab, and then we cross the patient over with idelalisib plus rituximab, we will save them. It is not true. It was not true with ibrutinib of Coutre, it's not true with chlorambucil. So that we learned that we have to start with the best treatment that we have. That's something that I think is a common message. Second thing, you probably didn't mention, it is true that in the HELIOS study, there is an advantage by adding ibrutinib compared to BR. But the common thing, again, compared to idelalisib plus BR as well, at the end, the effect, the efficacy of the combination is not better than the single drug.
Right. If you overlay the trials
without even overlaying, because one can always criticize that. But the question is that we know that with BR we can get like 18 months progression free. With ibrutinib we get 28 or whatever, not even reached. So we have the right comparator here would be the subsequent treatment with ibrutinib, then followed by BR at relapse or vice versa, whatever you want. So I think that there is no reason really to combine a chemotherapy with ibrutinib based on this trial. And this is something that we learned, we didn't expect. I mean, it is astonishing. I mean, as also Wyndham said, the combination with chemotherapy must work better. It is not true.
So I think that the comment around the survival, I think Wyndham, you said is valid, right? Because you see a survival benefit here. We'll present in a few months the PFS2 data from this trial too, and PFS2 is highly statistically significant for using ibrutinib first too. So again, it supports that using the better agent first And from us as a company, you know, the crossovers are great, but it's really very clear that even with crossover, we can't catch some of these patients.
No, that's definitely true because you're essentially giving somewhat ineffective therapy, ofatumumab, single agent rituximab in the case of the IDELA trial, and you're allowing the natural history of the disease to play out for 6 months, a year, before you can put them on one of these drugs. And so you have all the problems associated with even harder to treat disease.
It is a little, Paulo said this a little bit earlier, but I thought it's really intriguing with this is that, you know, when we start giving, especially chemotherapy or chemoimmunotherapy, we're actually creating a new illness there where it's not the natural history of CLL because now they're exposed to drugs and they're responding to that selective pressure on them. So we're coming out with new ones. So again, does it get back to the fact that, you know, the same thing is you want to give the best therapy first so you're not getting into CLL that may have resistance or mutations that may make it not as effective for your second or giving the drug second or third line or stuff. Again, going back, I'm a more solid tumor guy, but you know, the lung cancer, the issue is that patients deteriorate too quick, so many don't get a second line therapy, where this one may be more, you've changed the biology of the illness by giving especially the cytotoxic piece of it, but even maybe rituximab changing your immune milieu. It may be, again, a different microenvironment, as you mentioned earlier, by the time you get to then giving the ibrutinib. So it's a interesting, you know, to try to figure that out.
Yeah, so Steve, I think that the interesting part of this trial would have been if we had a single agent ibrutinib, an I versus placebo BR versus ibrutinib BR. That would have been,
sure.
But in some ways, the critique of ofatumumab and chlorambucil's comparators, BR is a really good comparator in this setting because 40% of patients in the relapse setting are getting BR. I think the question that you really asked is, so in places like in Colombia and in Brazil or in other places here in Latin America where BR is used as a standard of care, I guess the real question is what does this really mean now for Latin America? And I think you said it right. Is it ibrutinib by itself or is ibrutinib plus BR? I think that's the conundrum, I think, now to really face. I think it's a question of your philosophy of treatment.
Yeah, I think, I mean, if you could get ibrutinib either way, I see no reason to give it with chemotherapy, to give it with BR. There's just, certainly based on that trial, there's no reason for that.
So I think that the data we're seeing here, and just to your point, John, about how chemotherapy may well and probably does change the natural history in large measure, maybe because we're selecting out 17p. You know, through years and years of data in follicular, that's less clear. There have been lots of randomized studies where it's been, well, not lots, there's been one from NCI, watch and wait versus early chemo, et cetera. And you just don't see these same kinds of things as you're seeing here. So I do think that what we're seeing here may not be fully extrapolatable to follicular mantle cell. I just think we have to realize that these all may be quite different vis-a-vis induction of selective resistance through chemotherapy.
And I think, you know, part of your point on there, again, I thought it was very interesting that if you watch and wait, the small clone or the microclone of the you know, with P53 doesn't change, which again then it's maybe getting back to that microenvironment, is that when you're giving the chemotherapy in this setting, you're taking away the other CLL cells that might be suppressing that clone, giving it then the selective pressure versus just time, you know, where it's just growing up.
One last question.
Since the introduction of these new drugs, it seems like we are aiming to avoid chemotherapy. And is that really our endpoint, or should we try to maybe combine better induction treatments and aim to have a minimal residual disease, a negative minimal residual disease, and maybe try not to have patients in chronic therapy, because having chronic therapy is also an issue. So if I imagine if a fit patient can have a complete remission with a negative minimal residual disease with chemotherapy, maybe that's better than having chronic therapy forever. So I think we're all trying to avoid chemotherapy, but is that our real endpoint? Shouldn't we try to have an endpoint with trying to have a negative minimal residual disease?
So let's hold that issue to later in the program when we'll have a talk on MRD, and then, because I think there's many facets to that question.